Cognitive Behavioral Therapy. Boost your self-esteem and become free from anxiety, panic, and anger. Written by Zimbab Winston. Narrated by Rory Young. Chapter 1. Cognitive Behavior Therapy. What is cognitive behavioral therapy? Cognitive behavioral therapy, CBT, is a form of psychiatric therapy that focuses on customizing inefficient emotions, habits, and thoughts by interrogating and uprooting negative or illogical beliefs. Considered a solutions-oriented form of talk treatment, CBT rests on the idea that ideas and understandings impact conduct. Feeling distressed sometimes could misshape somebody's perception of reality. CBT aims to identify harmful ideas, assess whether they are a precise representation of real life, and, if they're not, utilize methods to challenge and overcome them. CBT was founded by psychiatrist Aaron Beck in the 1960s, following his disappointment with Freudian psychoanalysis and a wish to explore more empirical ways of therapy. CBT also has roots in rational emotive behavioral therapy, REBT, the brainchild of psychologist Albert Ellis. CBT is proper for people of all ages, including children, teenagers, and adults. Proof has installed that CBT can attend to numerous conditions, such as significant depressive disorder, anxiety conditions, trauma, eating disorders, obsessive-compulsive conditions, and many others. CBT is a preferred technique of treatment amongst professionals and insurance providers alike, as it can be effective in a brief time period, generally 5 to 20 sessions, though there's no set time frame. Research suggests that CBT can be provided efficiently online, in addition to face-to-face therapy sessions. How does CBT work? CBT focuses on present situation and feelings in real time, rather than youth events. A clinician who practices CBT will probably ask about family history to get a better sense of the entire individual, but won't spend inordinate time on past events. The focus is on what an individual is telling themselves that might lead to anxiety or disruption. An individual is then motivated to deal with reasonable concerns virtually and to challenge irrational beliefs, rumination, or catastrophizing. For instance, a person who is upset about being single would be encouraged to take real measures, but also question any unnecessary negativity or unwanted premise, "I will be alone forever and ever," that they attach to this contemporary fact. Chapter 2. Use cognitive behavior techniques to boost your beauty and self-esteem. I began using the term prettiness and self-confidence after a journalist asked me to specify the psychological difference between beauty and beauty. She asked, why do some people feel appealing even if they do not have model-like functions, although as others, like some sexy fashion models, on-screen actresses, and others who are well known for their prettiness, don't necessarily feel this way? I said to the journalist, physical functions are only a part of what makes an individual attractive, and her question was more about an individual's beauty self-confidence. You too may find this term useful in thinking of how you feel about your appearance. You see, attractiveness is more complex than meets the eye, a problem I have written about in former posts here. It is valuable to remember that beauty is both a physical and psychological experience. It's based upon 3 qualities: how we actually look, genetics; how we look after ourselves, health and grooming; how we feel about how we look, positive self-regard. The combination of these qualities is what I call prettiness self-confidence. Having one of them, good genes for instance, without the others, good grooming or positive self-regard, can cause a failure to feel appealing no matter how one appears to others. This part of the book is about ways to enhance beauty self-esteem using cognitive behavioral methods. Bear in mind that I'm not an appeal expert in the standard sense. That is, I am not a style or style authority, And these aren't attractiveness tricks that are sure to change your life. I, like lots of you, am sick of hearing those how-to ideas in commercials, publications, reality programs, books, and blog sites. Have you Googled beauty lately? We have become so accustomed to being told what we really need to fix that we forget that the entire concept of repairing actually detracts from feeling appealing. Instead, as a psychologist, I actually believe feeling better about ourselves requires internal work, and this applies to our appearance too. I help other people identify their thoughts and feelings about their self-image and find sensible ways to improve them. To achieve that goal, we need to understand the cognitive behavioral patterns we have about prettiness, learn how to modify them, and after that, use new ones to support our prettiness self-confidence. Below are 3 cognitive behavior therapy, CBT, techniques applied to the experience of attractiveness, starting with typical beliefs others have about prettiness, followed by a behavioral strategy that can be practiced to achieve change, and ending with a cognitive shift that enhances beauty self-esteem. Exercise 1. Cognitive belief. People tend to really believe that beauty is based upon a reality created by others. The truth is that you can learn how to define your self-image based upon your own requirements, rather than the reality created by your culture. Behavior pattern. Jot down 3 physical features and 3 aspects of your character that you like the most. If you have a difficult time thinking of any, try thinking of the features you are least critical of. For example, it could be, I work very hard, I like my eyes, I'm truthful, I'm a devoted good friend, I'm a really good athlete, and I have thick hair. Now put your list in order of importance and sophisticated by writing 1 sentence about each element on your list. Expected change. If you are like most men and women who have made this list, you will likely see the physical features you wrote were ranked lower than ones about your character. Though it might appear clear, this exercise puts physical attractiveness in perspective. It helps remind us that the core of our self-confidence is based upon personality qualities more frequently than our physical functions, even if our culture has us thinking otherwise. Physical attractiveness is just one element of our identity. Appearance is all about a lot more. Exercise 2. Cognitive belief. Looks matter to many people, but many puzzle beauty with perfection. Though no one truly looks flawless all of the time in each way, it is a belief supported by our media-driven culture. We all have had bad hair days, blemishes, bloating, and so forth, but airbrushing and Photoshop can really make them disappear. You can learn how to hang on to your imperfect core self-image, the sense of yourself that remains steady despite flaws, by acknowledging that variability is a fundamental element of true appearance. Behavior pattern. This exercise concentrates on your physical functions. Jot down 3 that you really believe are most attractive to you. Again, if you find this challenging, choose the 3 features you find least unappealing or ones that others tell you are appealing to them. For example, you may choose your curly hair, green eyes, and white teeth. Specify each feature in a sentence like, "My white teeth are attractive, especially when I smile." Use these to begin to identify the core of your prettiness, self-confidence. Expected change. Remember, no one has perfect features, but everyone has at least a number of appealing ones. Those can add to the core of your self-image. You can learn how to use them for confidence and to improve your prettiness self-confidence. If you have curly hair, bring attention to it by wearing cool hats. If you have good eyes, wear clothes, makeup that highlight the color. Healthy teeth? Keep looking after them and use your smile to feel good about your looks. If you change the equation between excellence and beauty to a more reasonable definition, the chances are you are going to have the ability to improve your attractiveness, self-confidence. Workout 3. Cognitive belief. We are our own worst critics. Only few people find as many faults with their appearance as we do. We can change the way we speak with ourselves by changing negative thoughts and unreliable internal discussions with more positive, practical ones. Behavior pattern. Look at yourself in the mirror, and after that, listen to the very words that come into your head. Ask yourself, is the tone critical? Do the words remind you of anybody or sound comparable to those your mom once said? Your father? Siblings? Schoolmates? Then question the credibility of these words. Are they really precise? For example, do thick eyebrows truly make you look unattractive? Do the extra 5 pounds you carry mean you are fat? Now rewrite these discussions as though you were speaking to your good friend, sister, or daughter. If a good friend asked you how she looked, what tone would you use? Just look in the mirror and use that tone in an internal discussion you have with yourself. Expected change. We can move the way we see ourselves by practicing constant, encouraging internal dialogues. Instead of being critical and fixing ourselves, we can try to look the best we can and accept who we are. Use your own kinder internal mirror as a constant source of prettiness self-esteem, and you're going to feel and look more attractive. These are just some of the inaccurate ideas about attractiveness that have become hardwired into our thinking, but that can change by using the cognitive conduct strategies. The result is a shift in our internal lens that builds, rather than repairs, long-term self-confidence and beauty self-confidence. All of us should have to feel positive regard towards ourselves, and we clearly can't rely on our society to make that happen. CBT has been revealed to help people change attitudes, beliefs, and habits. Why not apply this method to change our method to prettiness? Chapter 3. How to Stop Believing the Negative Ideas of Depression. Countless women and men experience clinical depression each year. Being depressed is a miserable experience, as I know not just from my scientific work, but from personal experience. It's difficult to feel fully alive when you're down the whole time and having a hard time to find satisfaction in any activity. Poor sleep, low energy, mental fog, and other symptoms contribute to the pain. While there are very effective forms of treatment for depression, lots of people don't find them helpful or get only limited relief. An example would be the following. In the STAR-D trial, one of the largest depression treatment studies to date, only about 1/3 of depressed individuals were depression-free after 12 to 14 weeks of treatment with a selective serotonin reuptake inhibitor, SSRI. That was a better result than placebo, but it left 2 out of 3 individuals with significant signs of ongoing depression. Reliable forms of psychotherapy like cognitive behavior therapy, CBT, result in similar results, with many individuals improving but large numbers continuing to struggle with signs. Combining medication and psychotherapy, while partially better, is not the magic bullet of depression treatment. An example would be the following. In the STAR-D research study, about half of depressed individuals were still depressed, even after 12 weeks of medication plus 12 weeks of cognitive therapy. Mindfulness-based cognitive therapy. These constraints have caused the search for other possibly helpful treatments. I recently talked to psychiatrist Dr. Stuart Eisendrath about one such treatment called mindfulness-based cognitive therapy, MBCT. As the name indicates, it integrates the best-tested psychotherapy for depression with practices in conscious awareness, which involves focusing on the present and letting go of resistance to reality. Most kinds of psychological therapy concentrate on trying to get rid of signs. Traditional cognitive therapy, for instance, teaches an individual to recognize and challenge the negative automated thoughts that are very common in depression. So if your mind tells you, "You're such an idiot, you're always screwing things up," your therapist would work with you to identify those ideas and consider the evidence for and against them. Together, you would aim to develop more useful and fact-based perspectives. MBCT offers a very different approach in which you would work to change how you relate to depressive thoughts. Eisendrath used this handy metaphor to explain. If you are walking down the main street of a town, you may see some storefronts with various depressive thoughts on display, he said. Typically, in depression, you would get into the store and purchase those thoughts, and after that go back out and start walking down the street having those ideas with you. Cognitive treatment would also involve going into the store and straight engaging with the thoughts. You might explain to the shop owner that the thoughts on display are deceptive, implicate them in incorrect marketing, and need that they change the thoughts. Perhaps the shop owner would nod understandingly, agree with your points, and after that refuse to change the display. In contrast, a conscious response to the ideas includes seeing them through the window without entering into the store. You see the depressive thoughts in the store, said Eisendrath, and you do not get rid of observing those ideas. However, you don't enter and purchase them, and you don't have to carry them with you as you go down the street. This technique can be very handy for the ones that struggle to change their negative mindsets, which in my experience is a large percentage of individuals with depression. Even when they know logically that their thoughts are unrealistically negative and that they are being too hard on themselves, the ideas stubbornly continue. And paradoxically, discussing with your negative thoughts can make them appear more important, like an issue that has to be fixed before you can proceed and be in your life. A mindful response to depressive ideas allows you to let go of the struggle with them and to just exist side by side together with the ideas. You're able to continue walking down the street, said Eisendrath, and you can still go where you want in life, even with the negative automatic ideas. Mindful responses to depression signs. There are numerous strategies for responding mindfully to depressed mindsets. What all of them have in common is bringing our attention to what is happening now and adopting an attitude of approval. Just remaining in this moment helps reduce depression because you are not laying on that negative story about the future, said Eisendrath. You're just concentrating on the present. Here are some practices for changing your relationship with depressive thoughts. Be in the body. Getting in touch with the body is one of the most efficient ways of letting go of resistance and bringing your attention into the present. Eisendrath advised asking yourself questions like, what do I see as I am depressed right in this moment? A tension in the shoulders or chest? A headache? Rather than making these experiences a problem, be curious about your experience. What's going on in my body right now? Breathe. Like the body, the breath is always with you. Practice breathing with your ideas, feelings, and physical feelings. As the body opens to the breath, let your spirit open up to your experience just as it is. Focus on your senses. When you find yourself stuck in negative patterns of thought, come to your senses. Thoroughly note something you see, something you hear, and a touch experience you're aware of. The aim isn't to push the negative thinking to stop, but to change the channel, widening your attention past the narrow spotlight of upsetting thoughts. Do what's important. Depression typically fosters a focus on how we're feeling, why we feel that way, and how we can get rid of bad feelings. Doing something important to you can be a very mindful way to break depression's preoccupation with itself. Instead of concentrating on how you are feeling, ask yourself what needs to be done. Taking out the trash? Are you doing the dishes? Are you writing that email you have been putting off? Let the action be as huge or as little as you can manage. Perhaps for now it's just brushing your teeth. Seeing ourselves move through depression is one of the most efficient ways to change our relationship with hard thoughts and feelings. Chapter 4. Psychodynamic versus Cognitive Therapy. Many current schools of psychotherapy reject practically all of the ideas of the original one, psychoanalysis, PA, and its updated version, psychodynamic treatment. Part of this is the analysts' own fault. They usually openly assaulted critics of some of the principles, telling them they needed to enter psychoanalysis. to find out why they were resistant to the ideas themselves. Simply put, if you found some of the ideas bothersome, you had a mental issue. Added to this was experts' tendency to continuously support some of the more improbable, plainly wrong elements of their theory, such as penis envy in women and schizophrenic mothers. In point of fact, psychoanalysis is an entire collection of theories that interrelate, and so are all of the other schools of therapy. To think that if one of the sub-theories is wrong, then they all should be wrong is black and white thinking, something cognitive behavioral (CBT) therapists themselves identify as illogical. And speaking of cognitive behavioral therapists, that is precisely what a lot of them did in C's to psychodynamic treatment, while doing so threw out the child with the bathwater. One of the more useful ideas from psychoanalysis, something that the majority of us acknowledge implicitly in our everyday lives, is that of defense mechanisms. As originally specified by Sigmund Freud, the creator of psychoanalytic treatment, a defense mechanism is a method developed by an individual, subconsciously, to safeguard against anxiety, specifically the anxiety created by disputes within the mind over somebody's biological impulses versus the values of the individual learned from his or her cultural milieu. For instance, when somebody's desire to have sexual relations with a complete stranger conflict with a belief in the social convention of not making love beyond marriage, unsatisfied emotions of anxiety come to the surface. To minimize these negative feelings, the ego might employ one of the defense mechanisms to either deny the existence of or undo the forbidden impulse. The most common defense mechanisms are called regression, repression, response formation, isolation of effect, undoing, forecast, introjection, turning against the self, and somatization. Interested readers that aren't familiar with the various PA defense reaction can find definitions of practically all of them here. Cognitive behavioral therapists, instead of analytically oriented therapists, turn down the entire idea of the unconscious and defense mechanisms, although they typically seem to recognize their behavior symptoms and just call them something else. They believe that apparently aberrant or conflicted conduct stems mainly from unreasonable beliefs. The first cognitive therapist was Albert Ellis, who came up with his theory at least a whole decade before his model was hijacked by another psychotherapy guru, Aaron Beck. Ellis listed some of these illogical beliefs. It is an alarming requirement for adult human beings to be loved or approved by essentially each loved one person in their community. Someone definitely must be proficient, appropriate, and attaining in all important respects, otherwise one is an insufficient, worthless individual. People definitely have to act considerately and fairly, and they're damnable bad guys if they do not. They are equivalent from their bad acts. It is terrible when things are not the way one would really like them to be. Emotional disturbances are mainly externally triggered, and people have little or no capability to increase or decrease their dysfunctional feelings and behaviors. If something is or may be dangerous or fearsome, then one should be constantly and exceedingly concerned about it, and needs to keep dwelling on the possibility of it taking place. A person can't and must not deal with life's duties and problems, and it is easier to avoid them. Someone should be quite based on others and really need them, and one can't mainly run one's own life. A person's past history is an all-important determiner of someone's present conduct, and because something once strongly affected one's life, it should indefinitely have a comparable effect. Other people's disturbances are horrible, and one must feel upset about them. There is invariably a right, precise, and perfect solution to human problems, and it is awful if this perfect solution isn't found. Cognitive behavioral therapists are beginning to reluctantly admit that unreasonable beliefs are typically connected to one's upbringing as a child. They originally really believed, and many still do, that they only occur just because people are basically and innately illogical. So who is right? The CBT folks or the PA folks? Well, naturally both are right, and both are also wrong. Let me clarify. When I initially learned psychoanalytically oriented psychotherapy, I began to notice what somebody named The Last Psychiatrist discussed in the quote at the start this part of the book. Defense mechanisms were visualized by Freud as safeguarding the self against anxiety, but neurotic people were the most anxious people out there. Yes, indeed, defense reaction don't really stop anxiety at all. What defense mechanisms do, from my combined treatment perspective, is to block an individual's expression of inherent ideas and desires that run counter to the roles they feel they must play to maintain the consistent performance of their family of beginning, family homeostasis. If a belief or a desire disputes with that role, it needs to be blocked so that the individual does not change from their role behavior. This specifically is the change that's blocked. People actually try to exterminate parts of themselves that are incompatible with their social role, mortification. If this is indeed the case, it ends up being easy to see that the illogical beliefs noted by the CBTers also come in helpful. Many people use these beliefs to dissuade themselves from indulging in certain habits that they may otherwise want to do if they became self-actualized and stopped playing their role. Self-actualization is a term used by a third major overarching school of psychotherapy, emotion-focused treatment, which includes Gestalt treatment and client-centered therapy. It means the realization or satisfaction of a person's skills and potentialities. For example, a woman with a sex role dispute who secretly wants to be a vocalist rather than a homemaker as her sexist family needs will stop herself from being a successful vocalist if she thinks, overgeneralizing, that having actually failed one audition in variable means that she will never ever pass one in the future. That holding true, why bother trying it in the first place? Simply put, the illogical beliefs noted by Beck and Ellis serve the exact same function as defense mechanisms. One could say, in fact, that they're defense reaction. I once suggested to Albert Ellis during a Q&A at a therapy conference that maybe unreasonable beliefs and defense mechanisms serve the same purpose. He naturally launched into an ironical tirade at me for bold to even think something like that. Chapter 5. Is cognitive therapy a treatment for misophonia? Last year I had the pleasure of speaking with Arjan Schrader and Nien K.C. Vulink in regard to their 2017 short article, Cognitive Behavior Therapy is Effective in Misophonia, an Open Trial. Please note that Dr. Schroeder at the time was a doctoral student under the guidance of Dr. Damien Dennis. Writing this book was rather delayed, yet I think the timing is appropriate. At least 3 to 4 times a week, somebody with misophonia asks me if CBT works. Apart from this, there are many medical professionals and researchers suggesting CBT as a standalone treatment for misophonia, instead of as a part of a larger survival skills management plan. In their paper, the authors report that CBT is effective in 48% of their clients. Especially, the criterion for effective was showing a 30% or greater reduction in their symptoms, as gauged by the really same scale that this research team created, the A-MISO-S. The authors beware to point out that this is not a claim that CBT is effective. Rather, it is a candid reporting of the results of their own open trial, i.e., their interference was helpful to almost half the individuals, but only with a 30% reduction of signs. It is essential that we both view and use this information to notify further treatment research. It is even interesting that even though the title of the chapter suggests that the researchers used CBT, their interference actually included a lot more multifaceted approach. Notably, what these and many other medical professionals call treatment, I would define as coping skills development. Yet, for the moment, let's put this distinction aside and call it rhetorical, although ultimately I do believe it is important. First, it is very important to discuss that Arjan Schrader and the AMC group suggested that misophonia ought to be classified as an OC and related disorder in the DSM-5 in their 2013 paper. At the time, Schrader was just starting to look at misophonia, as were others in the field. Aside from that, the classification of OCD changed to OC and associated conditions from the DSM-4 TR to DSM-5. This is also part of the confusion that continues to negatively impact analysis. That is, the DSM is far from a best diagnostic instrument, to say the least. For the record, Dr. Dennis's and Schrader have both told me that they no longer totally agree with this original notion. That is a really crucial step for those that experience misophonia, and for those who are at the leading edge of misophonia research. Significantly, other scientists still suggest that misophonia is an OC and associated disorder. As a result, these scientists continue to suggest interventions, such as graded direct exposure treatment, which I will discuss later in the post. This still leaves us in a great deal of confusion. It's interesting to look a bit farther into this. One of the reasons misophonia is continuously compared to other psychiatric disorders could have to do with the higher prevalence of adult researchers intrigued by the disorder, as contrasted with early youth researchers. There is a misconception that kids don't have misophonia. That just isn't true. Many young children have misophonia, meaning the exact same trigger sounds followed by an immediate fight-flight response. In a kid, one can see this reactivity in its more organic form. Children react with a variety of discernible habits when exposed to set-off noises. These habits include crying, positioning their turn over their ears, running away, and yes, sometimes aggressive words or gestures toward another, if the sound is originating from an individual. Nevertheless, most of the time, and I'm not saying all of the time, when the trigger sound is eliminated, the kid instantly appears to go back to homeostasis, or a calm state. When you see this, the idea that a child is obsessing over the sound fails. Again, research tells us that misophonia co-occurs with various psychiatric, developmental, and health conditions. Because of that, it is possible that these disorders may overlap. Having said that, it is definitely not definitive. Seeing misophonia in a really young child also unmasks the idea that anger is the only feeling involved. I have seen children crawl under sofas rather than be aggressive. Back to the interview. Why was I surprised by what I heard about the treatment at AMC? Well, as the Scholastic paper suggests, I assumed I was going to hear about CBT. Yet, the AMC misophonia treatment plan includes much more than CBT. The treatment paradigm includes group treatment that helps victims disconnect negative emotions from noises, in addition to attention training and some desensitizing to the sounds. Still, concerning desensitization, the person was in control of the sound exposure in the treatment trial. So, do not confuse this with systematic desensitization, graded exposure therapy, which I'm going to address later. As a matter of fact, Dr. Dennis's is adamant that he doesn't have faith in this kind of exposure treatment for misophonia. Although, the short article defines these 4 aspects of treatment as different kinds of CBT. I think it is worth exploring each facet on its own. Let's start with group therapy. As Dr. Schrader mentioned, it is valuable for people with misophonia to meet others with misophonia. This is exactly why the group chose group therapy. As Dr. Schrader said, and I am paraphrasing, meeting others with the same disorder helped people to feel less alienated. Definitely, group treatment can be tough for the ones with misophonia. Yet, if the AMC team had the ability to supply an environment where group support was handy, then this is important information to consider. We all know that people with misophonia often utilize support groups. I want to know more about how the AMC group avoided the apparent challenges to misophonia group therapy. Next, let's look at the idea of attention training. Part of the treatment involved participants playing physically oriented games, meaning bouncing a ball attached to a paddle, in order to distract them while dealing with activating circumstances, Example, while people are eating. Learning how to refocus attention from upsetting sounds can be useful. According to the researchers, once an individual knows they can refocus attention, it has a general calming influence. Because those with misophonia feel attacked by the environment on a continual basis, any control that one can implement is easing. Learning how to refocus can be empowering and may help one to feel a bit less overwhelmed by the disorder. However, there's a difference between some alleviation in terms of the tension that originates from living somebody's life with misophonia, as opposed to the neurophysiological reactivity the individual experiences in the moment. To put it simply, it is challenging to refocus one's attention in the face of trigger sounds or visual stimuli. Lots of people ask me why individuals with misophonia focus more on trigger sounds than other stimuli in the environment. I am usually asked by parents or caretakers, instructors, and others, why does a person look right at the individual who is making the sound instead of turning away? This is a question that is certainly worth some paragraphs. I have typically said that a simple clarification of misophonia is the brain is misinterpreting sounds as though they are pretty dangerous or harmful, and subsequently the fight-flight system is activated within milliseconds. Nevertheless, before we can translate or misinterpret acoustic stimuli, we must signal to it. Informing to sounds prior to realizing that we're doing so involves pre-attention. Science hasn't exposed precisely when attention moves from pre-consciousness to conscious. Nevertheless, our brains focus our attention based on a hierarchy of survival benefit without our knowing it, or choosing where or what to address. Eventually, the conscious mind permits us to think about what we are attending to and can make modifications. Remarkably, this is a procedure the AMC group has taken a look at in misophonia. I know I always use the example of a pet dog. Nonetheless, it's a great one because most of us have seen how our canine good friends react to sounds in their environment. Think of how a pet dog punctures up its ears when it hears a sound that could indicate a prospective danger. This could be a loud sound or a quiet sound. Without thinking or conscious awareness, the pet dog's brain will inform to these sounds as potential risk cues. We have all seen a dog go on high alert in response to a sound or perhaps a smell. The pet dog becomes watchful and stays that way till he knows he's safe. We see the pet dog's pre-attentive state, pricks up the ears even if sleeping, and we see the dog either returning to sleep, approaching the sound and possibly growling to safeguard territory or the pack, or running under the closest space to hide. Retraining attention is definitely a reasonable idea on its face. Nonetheless, given the power of pre-attention, especially involving potential hazard, we should comprehend that this is an extraordinarily uphill struggle and exceptionally tough to learn. We are battling against part of our survival system which has been perpetuated throughout advancement. I'm not saying we should not try to develop this skill, but do not expect it to be a trusted remedy. I do really believe that engaging in exercise that requires attention can help the brain override pre-attentive and even conscious attention to triggers. Trigger noises might be less obvious to a person in motion. Having said that, it is also true that we process sound and all of our senses in a different way when we are moving. Therefore, we may extrapolate that movement itself contributed to some of the trial's efficacy. Regardless, practicing this in a synthetic setup versus doing this in real life are really different. This is usually a pitfall with treatment studies. Lastly, separating trigger sounds from the feelings that accompany them within the group treatment process. Of course, this is practical, extremely useful. Yet, this is not a procedure as simple as separating an egg white from its yolk. Actually, it is a very complex process moderated, again, by autonomic nerve system stimulation happening before cognition can be employed. The ability to use cognition to separate trigger sounds from emotions is also affected by age, development, and variations in character, memory, and far more. It is a really crucial objective for individuals with misophonia. Yet to understand the complexity of the connecting forces of automatic unconscious reactivity and the mindful statement of an emotion is far from easy. In conclusion, we can't hold up the CBT flag for misophonia treatment just yet, and it appears evident that more scientists concur about this, while also coming around to what misophonia patients have known the whole time. Graded direct exposure therapy for the purpose of habituating to sounds doesn't work. It is great to see psychologists and psychiatrists trying to find misophonia treatment. Having said that, I hope as the research progresses, with more unity and knowledge, we will also move toward more multidisciplinary research and treatment trials. Chapter 6. Social Healing Treatment. Social healing treatment is a cognitive behavioral intervention created to help bring back a more capable mindset to youths with schizophrenia by enhancing social skills and encouraging more participation in social activities. The goal is to help people during first episode psychosis increase the amount of time they spend actively involved in social settings to prosper in their community, rather than simply survive as outsiders and consequently preventing long-term social disability. When it's used. Social healing-oriented cognitive behavioral therapy is used to identify and deal with the needs of teenagers and young people with early psychosis, multifaceted comorbidities, and severe social specials needs who aren't motivated to engage in organized activities. Supporters suggest that social recovery treatment, plus early interference at the time of the first episode of psychosis, is critical for preventing the early social decrease associated with a bad, long-lasting diagnosis for schizophrenia, because inspiration to change is greatest in the early phases of diagnosis. What to expect. In addition to helping people adapt to work, education, and leisure activities by learning and practicing necessary skills in a safe environment, social healing interventions intend to reduce any feelings of anxiety or despondence that may disrupt social success. Patient and therapist work closely together to establish social objectives and expectations, then match those objectives to appropriate firms and activities, like professional counselors, academic groups, and recreation center that host sports and other social activities. Meanwhile, treatment concentrates on reducing any negative emotions that are interfering with the capability to participate in new activities. How it works. Historically, there has been some dispute among psychotherapeutic specialists as to the true value of social healing therapy as an early interference treatment for those with psychosis. While lots of these clients already get early interference services that can result in partial or even full healing, some lack the motivation to participate in conventional interventions and continue to have trouble with social functioning. These early social difficulties invariably become long-lasting problems of seclusion, alienation, and complete lack of incorporation into the community. Other than the personal effects of functioning impairment, proponents of social recovery therapy mention the financial stress on the community as a consequence of lost efficiency. Early research studies suggest that social recovery-oriented cognitive behavioral therapy with early interference is well received and helps increase the amount of time clients invest in systemized activities by as much as 8 hours a week. Ongoing research is helping to figure out the long-lasting benefits and effects of social recovery therapy for people with schizophrenia and for civilization at big. What to try to find in a social healing therapist. Look for a certified mental health professional with specialized training in cognitive behavioral therapy, knowledge of social recovery interventions, and experience working with more youthful people in early phases of schizophrenia. In addition to these qualifications, it is necessary to find a therapist with whom you and your family feel comfortable working. Chapter 7. The 4 Downsides of Cognitive Therapy. For all its effectiveness, cognitive therapy also has its weaknesses. Cognitive treatment is a generic term that describes diverse cognitive approaches to modifying human experiences and activities. This review concentrates on cognitive therapy that concentrates on altering negative self-concepts. This approach is based upon the theories developed by A. Beck and A. Ellis. The self-focused cognitive approach presumes that it is illogical or negative cognitive beliefs about the self, rather than negative activating experiences that cause negative emotional states, or depression or anxiety, and dysfunctional conduct. The behavior includes a sense of defeat and the withdrawal of financial investment in people and in standard goals, and also an intensified sense of vulnerability. The purpose of cognitive therapy is to reorganize the client's unreasonable, negative, and/or distorted beliefs into reasonable, accurate, or positive ones. Although self-focused cognitive treatment has been shown to be remarkable to medication treatment for symptoms of depression and anxiety, it also suffers at the very least the following weak points. First, this model appears to confuse the signs, i.e. negative self-concepts, of depression with its cognitive causes. Examples of the negative cognition include low self-esteem, self-blame, self-criticism, negative predictions, unpleasant memories, erroneous analyses of experiences, all-or-nothing thinking, dichotomous thinking, leaping to conclusions, selective abstraction, overgeneralization, or exaggeration of negative experiences, the presence of a negative cognitive shift. Example, positive info pertinent to the person is filtered or blocked out, while negative self-relevant info is readily confessed. Simply put, for those people, negative cognitions penetrate internal conversations about self-evaluation, attributions, expectancies, reasonings, and recall. Are they the cognitive causes, or are they the symptoms? I think that the former instances all represent the signs. In other words, they are not the cognitive reasons that people engage in self-blame, exaggeration of negative experiences, or other types of distorted thinking. Second, this cognitive therapy uses such terms as negative self-concepts, irrational beliefs about the self, dysfunctional self-concept, and biased cognitions about the self, as though they are associated and interchangeable. In fact, they have varied meanings. Research has revealed that the valence of evaluations, that is, being positive or negative, is independent and separate from the accuracy of evaluations. In a lot of cases, clients' appraisals and reports of their negative or distressful experiences are quite logical, sensible, and accurate. For instance, their experiences of sexual or physical abuse at the hands of another or the catastrophes of their loved ones have left huge scars in their life. In such scenarios, cognitive restructuring exercises, with their focus on reframing reality and not on changing it, don't handle the true issue. Third, research has shown that positive self-evaluations could be inefficient and maladaptive. It is often the positive instead of the negative self-assessment that is characterized by inaccuracy and predisposition in the fields of health, education, and the workplace. Fourth, the self-focused cognitive model puts a strong focus on taking a look at the association between negative thoughts and psychological dysfunction, but it has not replied the question of why individuals choose to focus on their negative characteristics when the positive examination of the self is more accurate. Neither cognitive model sufficiently reconciles the two types of finding: 1. Self-blame bias, and 2. Self-serving predisposition. Research has revealed that people have the inspiration to see the self favorably and stay away from an unfavorable self-concept, displaying a self-serving bias consisting of blaming failures on the situation while taking credit for success. Chapter 8. Acceptance and Commitment Therapy. Acceptance and Dedication Therapy, ACT, is an action-oriented approach to psychotherapy that comes from standard behavioral therapy and cognitive behavioral therapy. Clients learn how to stop avoiding, rejecting, and struggling with their inner feelings, and instead accept that these deeper emotions are proper responses to certain situations that should not stop them from progressing in their lives. With this understanding, clients begin to accept their problems and hardships and commit to making necessary changes in their behavior, despite what's going on in their lives and how they feel about it. When it's used. ACT has been used efficiently to help treat workplace stress, test anxiety, social anxiety disorder, depression, obsessive-compulsive disorder, and psychosis. It has also been used to help deal with medical conditions like chronic pain, substance abuse, and diabetes. What to expect. Working with a therapist, you're going to learn how to listen to your own self-talk, or the way you speak with yourself specifically about traumatic events, troublesome relationships, physical limitations, or other issues. You can then decide if a problem needs immediate action and change, or if it can, or must, be accepted for what it is, while you learn how to make behavioral changes that can impact the circumstance. You might look at what hasn't worked for you in the past, so that the I therapist can help you stop repeating thought patterns and habits that are causing you more problems in the long run. And when you have faced and accepted your present problems, you make a dedication to stop fighting your past and your feelings, and instead begin practicing more positive and positive conduct based upon your personal values and goals. How it works. The concept behind ACT is that it is not only inefficient, but also disadvantageous to try to control uncomfortable feelings or mental experiences, because suppression of these feelings eventually causes more distress. ACT adopts the view that there are actually valid options to trying to change the way you think, and these include mindful conduct, attention to personal values, and dedication to action. By taking steps to change their conduct while, at the same time, learning to accept their psychological experiences, clients can eventually change their mindset and emotion. 1. The ability to endure uncertainty. Studies have revealed that intolerance of uncertainty is a key part of anxiety, stress, and depressions. People who can't tolerate unpredictability typically keep away from circumstances, postpone, seek reassurance continuously, hold up acting, do extreme monitoring, and refuse to entrust. 2. The ability to recognize rumination. Rumination is when you are consistently bothered by a worry idea. When people ponder, their issue-solving capacity is decreased. If you are ruminating, it is typically best to wait to attempt to issue resolve until you can think of the issue without jumping straight into rumination mode. If you can learn how to recognize when you're pondering, you can use cognitive behavior therapy techniques, diffusion methods, or mindfulness methods to help you stop pondering. The best thing you can do when you're ruminating is accept that you are having whatever thoughts you are having, recognize that the ideas may not be accurate, and enable the thoughts to pass in their own time instead of trying to block them out. Trying to block out traumatic thoughts will just cause increased strength and intrusions of the ideas you're attempting not to have. 3. The ability to recognize idea distortions. Types of thought distortions include making excessively negative forecasts, underestimating your ability to cope, personalizing, mind reading, catastrophizing, shoulds and musts, making judgments of yourself or others that are black and white instead of gray, privilege ideas, meaning thinking that the regular rules shouldn't actually apply to you, and more. The key to recognizing thought distortions is to ask yourself what ideas you're having when you feel distressed. Some of these ideas are likely to be thought distortions. 4. The ability and determination to use mindfulness strategies. Mindfulness strategies can help reduce anxiety and increase willpower. Practicing mindfulness will help you stop avoidance coping, make better choices even when you're feeling anxious, and help you ruminate less. Try this 10-minute conscious walking exercise to get going. 5. The capability to talk to yourself kindly about your imperfections and mistakes. Criticizing yourself harshly when you make a mistake or when one of your personal flaws appears is very likely to cause rumination and avoidance coping. Research has shown that speaking with yourself kindly not only helps you feel better, it also increases your inspiration for self-improvement. Chapter 9. Does the 12-step program work because it's a type of cognitive behavior therapy? Most people think of AA as a spiritual process with its primary focus on giving everything up to God or a higher power. Implicit in this idea is a forfeiture of personal responsibility, free choice, and self-determination. The truth is, though, that AA most likely works because it shares many things with CBT, like thinking differently, acting in a different way, and actually taking personal responsibility for one's decisions. Undoubtedly, if we look carefully at AA, we see that in spite of its spiritual underpinnings and focus on working the 12 steps, it is a really behaviorally oriented process. An example would be the following. One of the core suggestions that AA makes is to change people, spots, and things. Simply put, to change one's regimens, repertoires, and actions. Surprisingly, this echoes the advice of Dr. Arnold Lazarus, who in 1958 was the first individual to introduce the terms behavioral therapy and conduct therapist into the expert literature, who often tells his clients to do things differently and do different things. Since it is a central tenet of CBT that thought and action can and do influence emotions and even brain chemistry, it is not a surprise that changing what we think and how we act can have an effective effect on how we feel, even to the degree of loosening the grip of powerful dependencies. Even the giving up to a higher power aspect of AA is firmly rooted in a behavioral dirt, in that AA members frequently say, "Pray like everything depends on God, but act a lot like everything depends upon you," and "fake it till you make it." Both of these little bits of guidance carefully mirror the cornerstone of CBT, particularly that how you act, so will you think and feel. Here is an example. People who conquer fears, phobias, and even obsessive-compulsive anxiety do so by refusing to act afraid, regardless of their fearful feelings and restless ideas. With time, this leads to genuine shifts in thinking and feeling, so that they enter into alignment with the non-fearful behavior. For that reason, people fake it, not being anxious or phobic, till they make it, overcoming their fears. What's more, working the steps farther enhances the restorative thinking and corrective action, meaning CBT, elements of AA, simply because it motivates people to develop more self-awareness, a browsing and brave ethical stock of ourselves, face fears, make amends, engage in self-monitoring, continue to take a courageous inventory, take some responsibility, when we are wrong, immediately confess, and change one's consciousness through prayer or meditation. In addition, the AA group process, consisting of self-disclosure, mutual support, and observational learning, parallels tons of the features found in cognitive behavior therapy groups. Now, this isn't to say that AA and CBT are associated or interchangeable, but that AA might owe its success to the parts of the program that are a lot like CBT, one of the most empirically supported and evidence-based therapies in the psychological arsenal. This has been Cognitive Behavioral Therapy. Boost your self-esteem and become free from anxiety, panic, and anger. Written by Zimbab Winston. Narrated by Rory Young. Cognitive Behavioral Therapy. Retrain your brain and heal from trauma. Written by Zimbab Winston. Narrated by Rory Young. Chapter 1. Cognitive Behavior Therapy Techniques That Work. Cognitive behavior therapy techniques come in many sizes and shapes, offering a wide variety to pick from to suit your preferences. You and your therapist can mix and match techniques depending upon what you're most interested in attempting and what works for you. You can also try the following cognitive behavioral therapy techniques as self-help. Behavioral experiments. In cognitive behavior therapy, behavioral experiments are developed to evaluate thoughts. Here is an example. You might do a behavioral experiment to check the idea, if I criticize myself after eating way too much, I'm going to eat way too much less, versus, if I speak with myself kindly after overindulging, I am going to eat way too much less. To do this, you would try each method on different occasions and monitor your subsequent eating practices. This would give you unbiased feedback about whether self-criticism or self-kindness was more reliable in decreasing future overindulging. This type of behavioral experiment might also help counteract a related thought like, if I respect myself, it's like giving myself a completely free pass to overeat, and I'll lose all self-discipline. Thought records. Like behavioral experiments, thought records are also designed to check the credibility of thoughts. Here is an example. A clinical psychology student who gets negative feedback from a supervisor may leap to the conclusion, my supervisor thinks I'm useless. The student could do a thought record examining the evidence for and against that idea. Evidence against the thought could be things like, my manager gave me positive feedback yesterday, or my supervisor is enabling me to run evaluations and give feedback to clients. If she thought I was pointless, she probably wouldn't be enabling me to do that. Once you've taken a look at the unbiased proof for and against a thought side by side, you will have the ability to come up with more well-balanced thoughts to take its place. An example of a well-balanced idea may be, I made a mistake. Making mistakes is typical. I can learn a lot from this. My manager will be satisfied to see me learning from my mistakes and incorporating her feedback. Idea records tend to help change beliefs on a logical level, whereas behavior experiments might be more helpful in changing beliefs on a gut or felt level, or what you emotionally feel is really true, despite the unbiased evidence. Pleasant activity scheduling. Pleasant activity scheduling is a remarkably reliable cognitive behavioral therapy method. It's especially valuable for depression. Try the following. Write the next 7 days down on a paper, starting with today, that is, Thursday, Friday, Saturday. For each day, schedule one enjoyable activity, anything you enjoy that's not unhealthy, that you would not typically do. It could be as simple as reading a chapter of a novel, or eating your lunch away from your desk without hurrying. An alternative version of this method is to arrange one activity each day that gives you a sense of proficiency, or accomplishment. Again, choose something small that you wouldn't usually do. Go for something that will take you less than 10 minutes. An innovative variation of this strategy would be to arrange 3 enjoyable activities each day, one for the early morning, one for the afternoon, and one for the evening. Doing activities that produce higher levels of positive emotions in your life will help make your thinking less negative, narrow, stiff, and self-focused. Situation direct exposure hierarchies. Situation exposure hierarchies involve putting things you would typically keep from on a list, ordered from bad to somewhat better. For instance, a client with an eating disorder might make a list of prohibited foods, with ice cream at the top of the list and full-fat yogurt near the bottom. A client with social anxiety may put asking someone on a date at the top of her list and asking somebody for directions near the bottom. The theme of the list should show your most pressing problem, basically. For each product on your list, rate how distressed you think you'd be if you did it. Use a scale from 0 to 10. An example would be the following. Ice cream equals 10. Full-fat yogurt equals 2. Order your list from highest to most affordable. Try to have several items at each distress number so there are no huge jumps. The idea is to work your way through the list, from most affordable to greatest. You would likely experiment with each item several times over a period of several days, until the distress you feel about being in that situation is about half of what it was the first time you tried it, meaning you can eat full-fat yogurt with a level of distress that is 3 out of 10 instead of 6 out of 10. Then move to the next product up the list. Imagery-based direct exposure. One version of images direct exposure involves evoking a recent memory that provoked strong negative feelings. Let's take, for example, the earlier example of a medical psychology student being given critical feedback by a supervisor. In images exposure, the person would bring the situation of being given the feedback to mind and remember it in lots of sensory detail. That is, the manager's intonation, what the room looked like. They would also try to accurately identify the feelings and ideas they experienced at the time of the interaction, and what their behavioral urges were, meaning to run out of the room and cry, to get mad, and so forth. In extended imagery exposure, the person would keep envisioning the image in detail till their level of distress reduced to about half its initial level, say from 8 out of 10 to 4 out of 10. Images-based direct exposure can help neutralize rumination because it helps make invasive painful memories not as likely to set off rumination. Just because of this, it also tends to help in reducing avoidance coping. When an individual is less distressed by invasive memories, they're able to choose much healthier coping actions. This list of cognitive behavior therapy techniques is far from extensive, but it will give you a pretty good idea of the variety of strategies that are used in cognitive behavioral therapy. If you're working with a therapist and you have been doing your own reading about CBT, you can let your therapist know what methods you're excited to try. Chapter 2. When Cognitive Behavioral Therapy Doesn't Work. Cognitive behavior therapy, CBT, is a commonly looked into method to psychology. There are many research articles online touting its effectiveness for a broad number of psychological health conditions. If you have been a therapy client in the last number of decades, chances are you have been on the receiving end of CBT. Though CBT has a dirty secret. It does not work for everyone. I practice CBT, I have taught CBT, I have even been helped by CBT. That said, I have read a lot of research about CBT, and so far I have not found a single research study where each participant was cured of all symptoms by CBT. It does have a tendency to be efficient, and more than most other treatments for some conditions, but it is necessary to acknowledge the reality that it doesn't cure every sign for each person. Without acknowledging this reality, you might wind up blaming yourself or your therapist when CBT doesn't treat you. Sheesh, you might think, even CBT can't help me. I should be a very real lost cause. Nope. So what do you do when you have tried CBT for a while and do not feel like you are improving? Here are some ideas. Consider another kind of intervention. There are many approaches to treatment. If you have a therapist that you like to work with, you might inquire about what other interventions you could do together instead of, or together with, CBT. You may look around the self-help section of a bookstore and find a workbook or two that interest you. If lots of your problems are connected to relationships, perhaps couples or family treatment would be more beneficial. If you are creatively inclined, maybe meaningful arts therapy would be well worth looking into. Do you need to increase or reduce your dose of treatment? It can be hard to get momentum if you aren't seeing your therapist enough or doing enough work between sessions. If your signs are extreme, you might not be able to count on treatment alone and might consider a recommendation to talk with someone about medications. At the same time, in some cases, an individual needs more time between sessions to practice new abilities. Think about your present therapy dosage and discuss with your clinician whether it might really need to be changed. Try something therapeutic instead of treatment. It could be weird to hear a therapist say this, but sometimes people are actually helped by things besides therapy. Likewise, at times, treatment alone is inadequate. Supplementing or replacing treatment with other meaningful activities can be very valuable. Some examples: a meditation or prayer group, Journaling, reading self-help or inspiring writing, doing something creative, increasing social activities, increasing exercise, getting routine massage, spending more time in nature. Consider official mental screening. In many cases, a person's cognitive strengths and weak points, or their character style, can impact what treatments are best for them. Moreover, at times understanding these features of an individual makes the therapist better able to customize an intervention, even CBT, to better match your strengths and increase its effectiveness. Talk with your therapist, psychiatrist, primary care supplier, insurance company, or do a web search for a practice in your area that does mental or neuropsychological examination. Be ready for some hours of testing, and that includes long surveys and tests developed to look at different cognitive abilities, or attention, memory, executive functions. Do you like your therapist? Another body of research shows that the quality of the relationship between the therapist and the client represent most change in therapy. Rather than the treatment interference itself, it seems like the relationship itself has healing powers. This suggests that it is truly important to find a therapist with whom you feel safe, respected, and cared for. It could mean that you try some different therapists before you choose one to work with. It could also mean that you change therapists at some point in your treatment, maybe because you have grown, recovered, and changed, and need something new from the relationship. Remember, there's strong research supporting CBT to help a wide variety of individuals with a wide array of signs. It is a sensible place to begin for many people going into therapy, but it is not a remedy. If CBT has not helped you, or has not helped enough, you have alternatives. Chapter 3. Dialectical Behavior Treatment. Dialectical Behavior Treatment, DBT, provides clients with new abilities to manage uncomfortable feelings and decrease conflict in relationships. DBT particularly concentrates on offering restorative abilities in 4 key areas. First of all, mindfulness concentrates on improving an individual's capability to accept and be present in the present moment. Second, distress tolerance is tailored toward increasing a person's tolerance of negative feeling, rather than attempting to escape from it. Third, feeling control covers techniques to manage and change extreme emotions that are causing issues in a person's life. Fourth, social efficiency includes methods that allow an individual to communicate with others in a way that is assertive, keeps self-regard, and strengthens relationships. When it's used. DBT was initially developed to treat borderline personality disorder. Still, research shows that DBT has also been used successfully to deal with people experiencing depression, bulimia, binge eating, bipolar affective disorder, post-traumatic stress disorder, and drug abuse. DBT skills are thought to have the capability of helping those who wish to enhance their ability to control emotions, endure distress and negative emotion, be mindful and present in the given moment, and communicate and connect effectively with others. What to expect. DBT treatment usually consists of individual therapy sessions and DBT abilities groups. Individual treatment sessions include one-on-one contact with a skilled therapist, making sure that all healing needs are being attended to. The individual therapist will help the patient stay inspired, use the DBT abilities within life, and address challenges that might emerge throughout treatment. DBT skills group individuals learn and practice skills together with others. Members of the group are motivated to share their experiences and provide shared support. Groups are led by one experienced therapist teaching abilities and leading exercises. The group members are then designated homework, such as practicing mindfulness exercises. Each group session lasts around 2 hours, and groups typically meet weekly for 6 months. Groups can be much shorter or longer, depending on the needs of the group members. DBT can be provided by therapists in a number of ways. For example, some people finish the one-on-one treatment sessions without attending the weekly abilities group. Others might choose the group without routine one-on-one sessions. How it works. DBT is a cognitive behavioral treatment developed by Marshall Linehan, Ph.D., in the 1980s to deal with those with borderline personality disorder. Those diagnosed with BPD often experience very extreme negative feelings that are tough to manage. Those extreme and relatively unmanageable negative feelings are often experienced when the individual is engaging with others, good friends, romantic partners, members of the family. Those with borderline often experience a great deal of conflict in their relationships. As the name suggests, DBT is influenced by the philosophical perspective of dialectics, balancing reverse. The therapist regularly works with the person to find ways to hold two seemingly opposite perspectives at once, promoting balance and keeping away from black and white, the all-or-nothing styles of thinking. In service of this balance, DBT promotes a both and instead of an either or outlook. The dialectic at the heart of DBT is approval and change. What to look for in a dialectical behavior therapist. DBT presumes that effective treatment, and that includes group skills training, should pay as much attention to the behavior and experience of providers working with clients as it does to clients' behavior and experience. Hence, treatment of the service providers is an important part of any DBT program, and therapists should practice the abilities themselves. They need to know standard behavior therapy strategies and DBT treatment methods. Try to find a mental health professional with specialized training and experience in DBT. The Linehan Board of Accreditation, a nonprofit company, has developed accreditation requirements for clinicians. Besides, it is very important to find a therapist with whom you feel comfortable working. Chapter 4. Trauma-Focused Cognitive Behavior Therapy. As its name suggests, is a type of cognitive behavioral therapy that addresses the specific psychological and psychological health needs of kids, adolescents, adult survivors, and families who are having a hard time to get rid of the destructive results of early trauma. Trauma-Focused Cognitive Behavior Therapy, TFCBT, is specifically vulnerable to the unique problems of youth with post-traumatic tension and state-of-mind conditions arising from abuse, violence, or sorrow. Simply because the client is usually a kid, TFCBT usually brings non-offending parents or caretakers or other caretakers into treatment and integrates principles of family treatment. When it's used. Anyone who has experienced a single or repeated experience of sexual, physical, or mental abuse, or who has developed post-traumatic symptoms, depression, or anxiety because of the loss of a loved one or exposure to violence in the home or community can benefit from TFCBT. If a child or adolescent also shows serious behavioral, substance abuse, or suicidal ideation issues, other forms of treatment, such as dialectical behavioral therapy, could be better as an initial interference and can be followed up with a trauma-sensitive method. There's little evidence that trauma-focused cognitive behavior therapy is the best interference for adult war veterans with complicated trauma. What to expect. TFCBT is a short-term intervention that typically lasts everywhere from 8 to 25 sessions and can take place in an outpatient mental health clinic, group home, community center, hospital, school, or at-home setting. Cognitive behavioral techniques are used to help modify distorted or unhelpful thinking and negative responses and behaviors. At the same time, a family treatment approach takes a look at interactions among family members and other family dynamics that are adding to the problem and aims to teach new parenting, stress management, and communication skills. How it works. The trauma-focused technique to psychological therapy was first developed in the 1990s by psychiatrist Judith Cohen and psychologists Esther DeBlinger and Anthony Manarino, whose original intent was to better serve kids and adolescents who had experienced sex abuse. TFCBT has expanded for many years to include services for youths who have experienced any form of serious trauma or abuse. Early childhood trauma can lead to guilt, anger, emotions of powerlessness, self-abuse, acting out behavior, and psychological health issues like depression and anxiety. Post-traumatic stress disorder, which influences children and adults, can manifest in certain ways, like bothersome recurring ideas about the terrible experience, emotional numbness, sleep concerns, concentration issues, and extreme physical and psychological reactions to anything that triggers a memory of the trauma. By incorporating the theories and techniques of several therapeutic interventions, TFCBT can attend to and improve the signs of post-traumatic stress in youth. Chapter 5. Mindfulness-Based Cognitive Therapy. Mindfulness-Based Cognitive Therapy, MBCT, is a modified form of cognitive therapy that integrates mindfulness practices such as meditation and breathing workouts. Using these tools, MBCT therapists teach clients how to break away from negative idea patterns that can cause a down spiral into a depressed state, so they will be able to fight off depression before it takes hold. When it's used. MBCT was developed for those with recurring episodes of depression or distress to stop regression. It has been proven reliable in clients with major depressive disorder who have experienced at least 3 episodes of depression. Mindfulness-based relapse prevention may also be helpful for dealing with generalized anxiety disorders and dependencies. MBCT has also been revealed to improve symptoms of depression in some those with physical health conditions, such as vascular illness and terrible brain injury. What to expect? MBCT is group therapy with once-a-week, 2-hour sessions, led by your therapist as part of an 8-week program. You will learn meditation techniques as well as basic concepts of cognition, like the relationship between the way you think and how you feel. You'll also have the opportunity for more information about your depressive condition. On the days when there is no session, there is homework, which includes practicing breathing exercises and conscious meditation. How it functions. In some cases, typical unhappiness is an effective trigger for someone who has recovered from a depressive state to relapse into another bout of depression. Rather than try to stay away from or get rid of unhappiness or other negative feelings, one learns to change their relationship with these feelings by practicing meditation and other mindfulness workouts. These activities rebalance neural networks, enabling the client to move from automated negative reactions toward an understanding that there are other ways to respond to circumstances. By creating a routine meditation practice, clients can use the technique whenever they start to feel overwhelmed by negative feelings. When sadness takes place and starts to bring up the usual negative associations that activate relapse of depression, the client is geared up with tools that will help them change negative thought patterns with positive. Chapter 6. The 9 Best Ways to Relieve Your Memory Problems. The different methods and treatment are classified into 3 areas: traditional, complementary, and alternative. This categorization is based upon insurance reimbursement. Nearly 98% of standard approaches are covered by insurance coverage, while at least 50% are covered by complementary and 0% for alternative approaches. 1. Cognitive therapy, CT, and cognitive behavior therapy, CBT. Both methods are covered under insurance, yet are really different. Cognitive therapy is done by a speech and language pathologist, while cognitive behavioral therapy is done by a psychological health expert, such as a licensed psychologist or certified social worker. Cognitive therapy, CT, is the assessment and treatment of cognitive abilities, and that includes memory, attention, and executive performance, planning, sequencing, organizing, initiating, problem-solving, decision-making, and self-awareness. Through the education and training of offsetting strategies, cognitive treatment helps you complete daily jobs with greater independence and self-confidence. Making strategic adjustments to your environment, for instance, enables you to be more efficient and focused in everyday function. Cognitive behavioral therapy, CBT, is a type of psychological therapy that helps people change how they think, feel, or act so as to enhance their mood, reduce stress, or accomplish other important health and life objectives. Some objectives could be specific, like decreasing worrying or procrastination, although others can be more general, like determining why an individual's life appears to lack meaning, enthusiasm, or direction, and figuring out what to do about it. There are 3 parts to CBT. How you actually think, cognitive, can and does change your conduct. The way you think could be monitored and altered. The preferred conduct change may be affected through changes in the way you think. 2. Medications. If prescribed by an MD, most are covered by insurance, like methylphenidate, Ritalin, and dextroamphetamine, Dexedrine, can be extremely reliable for attention problems. Amantadine, Simitrel, is a drug that affects the action of brain chemicals called neurotransmitters, and that is sometimes used to deal with the ones with Parkinson's disease. Those medications have bad effects, but if they are quite effective, the benefits might surpass the downsides. Prevagen, a brain health supplement, has been revealed to help alleviate memory and sleep issues by binding to calcium cells and reducing damage done by the body's lessened production of calcium-binding proteins. The active ingredient responsible for this work is apiocorin, a protein found in jellyfish. The regular variation of Prevagen can be purchased at an organic food store, while a professional, more potent variation is sold through health practices. As always, it is very essential to consult with your neurologist before using any over-the-counter medication. 3. Unique Need Educator Tutor. Some state, Providence, and school systems might reimburse the cost. If you were in an automobile mishap, it is essential to have this included. A unique needs educator is trained in a wide variety of approaches to assist with memory problems. 4. Hyperbaric Oxygen Treatment, HBOT. In many states, such as Florida, Texas, and California, to name a few, HBOT is covered by your health insurance. Hyperbaric medication, now called hyperbaric oxygen therapy or HBOT, was invented as a method of dealing with decompression disease. Breathing pure oxygen in an environment of increased pressure delivers 20 to 30 times the amount to the body tissues. This approach helps supply more oxygen to the brain to boost brain regulation. A subset of this is oxygen therapy or the personal oxygen bar. 5. Nutrition. Most insurance businesses do cover a nutritional expert or dietitian. It is incredibly essential to eat an anti-inflammatory diet that enables the brain to heal, removing refined sugar, corn syrup, and any grains that can be fermented or distilled. A boost of omega-3 from wild sockeye salmon and tuna is beneficial. Additionally, spinach and other vegetables rich in antioxidants can help enhance your memory. Coconut, olive oil, and avocado are good sources of fats that help the brain heal and boost your storage and retrieval abilities. Drinking water helps the brain as well. 6. Neurofeedback. Neurofeedback can help the brain to end up being managed again and form new neural connections needed for attention, concentration, storage, and retrieval. This strategy uses a computer to give info to a person about his or her own brainwave pattern in the form of EEG activity, in order to train the individual to modify her or his own brainwaves. When the brain isn't functioning appropriately, proof of this normally shows up in EEG activity. Neurofeedback training, EEG biofeedback, helps a person to modify his own brainwave attributes by challenging the brain to learn to rearrange and function better. 7. Exercise. Do what you can to raise your heart rate so that you can get more oxygen to your brain. 8. Computer programs. There are some computer programs and websites devoted to enhancing your memory, such as BrainTrain, IQ, and Lumosity. There are other programs, however, the ones I've named are the ones that I know personally are really reliable. 9. Alternative methods. Most ads mention that certain herbs or holistic treatments can increase your memory. These over-the-counter items may help, but it is always best to work with an experienced practitioner instead of attempting to self-medicate. Even natural remedies can have serious bad effects if not used appropriately. Depending on your particular needs, an educated herbalist might recommend a product such as ginkgo biloba, ginseng, very blue-green algae, black cohosh, or swan zhao ren for memory improvement. Natural remedies that could be recommended for the ones with post-concussion memory troubles include Carbo vegetabilis, Cecilia terra, Hyoscyamus niger, Phosphoricum acidum, Helleborus, and Calcarea carbonica. Some people have found that taking certain nutritional supplements, such as 50 milligrams of vitamin B6, pyridoxine, and 100 milligrams of coenzyme Q10 daily, has helped to restore memory. It is necessary to be mindful, though, that excessive amounts of vitamin B6 can damage the nerve system. As with any substance, it is vital to first confer with your doctor to decide on what dosage, if any, is best for you. Polarity treatment might be valuable in solving attention and concentration problems, especially if the specialist has experience treating your specific signs. Chapter 7. Play treatment. Although at times used with adults, play treatment is a psychotherapeutic method primarily used to help kids ages 3 to 12 explore their lives and easily reveal repressed ideas and emotions through play. Therapeutic play generally takes place in a safe, comfortable playroom where only a few rules or limitations are forced on the child, motivating free expression and allowing the therapist to observe the kid's choices, and play style. The objective is to help children learn to reveal themselves in much healthier ways, end up being more respectful and empathetic, and discover new and more positive ways to resolve issues. When it's used. Healing play helps children with social or emotional deficits learn how to communicate better, change their conduct, develop problem-solving abilities, and associate with others in positive ways. It's appropriate for children going through or experiencing stressful events in their lives, such as a pretty serious illness or hospitalization, domestic violence, abuse, trauma, a family crisis, or a distressing change in their environment. Play therapy can help children with academic and social problems, learning disabilities, behavior conditions, anxiety, depression, sorrow, or anger, and also those with attention deficit disorders or who are on the autism spectrum. What to expect. The parent or caregiver plays a crucial role in play treatment for children. After carrying out a preliminary consumption interview with the parent, when the therapist collects info about the kid, and often a separate interview with the kid, the therapist can make an assessment just before beginning treatment. An assessment permits the therapist to choose the best treatment technique for the kid. In the playroom, the child is encouraged to have fun with really specific kinds of toys that motivate self-expression and assist in the learning of positive behaviors. Arts and crafts, music, dancing, storytelling, and other tools might also be integrated into play treatment. Play therapy generally occurs in weekly sessions for approximately 20 sessions long-lasting 30 to 45 minutes each. How it works. Play therapy responds to the special growth needs of young children, who usually reveal themselves better through play activities than through verbal communication. The therapist uses play and other creative activities to communicate with the kid and observe how the child uses these activities to express thoughts and feelings that are not uttered in words. There are two approaches to play therapy. Non-directive play treatment is based on the concept that kids can solve their own concerns given the right conditions and the flexibility to have fun with restricted guideline and guidance. Directive play therapy uses more input from the therapist to help accelerate results. Play therapists use both approaches, depending on the situations. Chapter 8. Cognitive Behavioral Therapy for Romantic Jealousy. How can we comprehend bothersome enviousness and help people cope better? That question has usually been asked by therapists, but answered by only a handful of them. Jealousy is a typical problem in treatment, but surprisingly little has been written in the cognitive behavioral therapy literature on how to help clients manage it. Jealousy is always about three people, where a single person views a hazard or insult to a unique relationship with a third individual. We can see envy in intimate relationships between brother or sisters, friends, among associates, and even in infants. In fact, animal owners report enviousness in their family pets, with horses and dogs demonstrating the greatest enviousness. We typically confuse being jealous with envy, but envy isn't about a risk to a special relationship, but rather about a hazard to one's loss of status or the perception of unreasonable treatment in a status or reward hierarchy. If you attend professional conferences, you can see the envy among leading competitors, who reveal both hostile and, in some cases, depressive envy. When they hear that somebody has gotten greater attention, they often gossip about their imperfections, but may also haven their own feelings of humiliation and defeat. I go over these emotions in my book, Psychological Schema Therapy. In 2015, I published a book on how we can understand and cope with extreme envious emotions, the jealousy remedy, learn to trust, overcome possessiveness, and save your relationship. I realized over years of practice that many clients struggle with emotions of jealousy, typically pondering, blaming, begging, threatening, and sabotaging their relationships. I could not find a self-help book to recommend to clients that drew on the advances in CBT, so I chose to supply this guide. Rather than as a failure of self-confidence or irrational should statements, I view enviousness as a close to universal part of humanity and an effort to deal with threats to important attachment figures in one's life. The evolutionary models of jealousy support this. Adult investment concept proposes that males can never ever be sure about the paternity of a baby, while females always know that they're the natural mother. Thus, males are more likely to feel threatened by sexual infidelity, while women are more likely than males to feel threatened by emotional nearness. Research on a vast array of cultures shows that this sex distinction in envy holds up. Another evolutionary process underlying enviousness is competition for minimal resources, which can also represent envy among brother or sisters and associates. People who experience intense envy in romantic relationships are afflicted by their strong attachment to their partner, while experiencing anger and anxiety about perceived external threats, others, or interlopers. These restless and ambivalent attachments fuel jealousy. Truth be told, the research shows that the greater financial investment a person has, the greater the possibility of enviousness. Nonetheless, this is balanced out if there is greater certainty in the relationship, as one can experience in many longer-term relationships. Jealousy is less common during the early phases of a relationship, since there's little bit invested, but it can increase as attachment increases with time. Attachment style also affects jealousy, with anxiously attached people experiencing more envy. Actually, those with a removed or avoidant attachment reveal less jealousy, since they're less dependent and focused on the need for a relationship. Contrary to well-known viewpoint, self-esteem isn't regularly related to envy. Undoubtedly, there are some cases in which higher self-confidence is manifested in greater assertion as the individual tries to set limitations on the infidelity and flirting of their partner. I claim that it is necessary to normalize and confirm the difficulty of jealousy, never ever telling the patient, "You shouldn't feel this way," or "Stop feeling jealous." But this is like telling a person in pain to stop complaining about the pain. I suggest making a difference between jealousy feelings, thoughts, and envious behavior. As a matter of fact, it is usually the behaviors that cause greater threats to the relationship. Those envious habits include interrogating, derogating, threatening, stalking, and withdrawing. We can recognize and test out the many jealous idea patterns, such as mind reading, "She finds him appealing," fortune telling, "He is going to run off with her," catastrophizing, "It would be the end of my life if she betrayed me," and overgeneralizing, "Guys cannot be trusted." While many negative ideas could prove precise, it is necessary to test them against opposing interpretations and evidence. I propose that many individuals endorse beliefs in emotional perfectionism, romantic perfectionism, and pure mind. Psychological perfectionism fuels jealousy, since the individual believes that they are supposed to only have positive and enjoyable feelings, or that their partner must have these flawless feelings. Thus, people want to get rid of their emotions, or their partner's envious emotions. That is unrealistic. Romantic perfectionism entails beliefs that one should never be attracted to or flirt with others, or that one's intimate partner must never have delighted in sexual or psychological intimacy with others in their past. Again, absolutely unrealistic. And pure mind is a kind of obsessive requirement that one can't tolerate blended or conflicting emotions, and that any negative or undesirable ideas and feelings must be purged. Again, an impossible job. Learning to live with noise, contradiction, disappointment, and doubt is a crucial part of reality. I think of envy as upset, worry, and as such we can use a variety of CBT methods to deal with these intrusive thoughts. Making use of the work of Adrian Wells, metacognitive treatment, we can think of intrusive thoughts as just thoughts, telemarketing calls, background noise, or clouds in the sky that go by. Detached mindfulness can help in disengaging and observing, rather than battling with these ideas. Clients can reserve jealousy time when they set up an appointment with their thoughts and postpone engaging with them till that designated time. This can help clients acquire greater control and detachment. At the time of the jealousy time, the individual can ask if ruminating and worrying is going to solve any issues, gain certainty, or result in productive action. If the conclusion is that it will not, then we introduce the acceptance piece. This includes approval of uncertainty and constraints of control, and even acceptance that things will not work out. Of specific value in this regard is what I call the dullness method, in which an individual repeats the feared idea, "My partner could betray me," ad nauseam, till they are tired and no longer care. Couples also really need to determine the ground rules of what their commitment means to them and what their expectations are. There are no universal guideline. Some people might accept more open relationships, though most will not. Interacting discontentment also can involve helping clients learn better ways of expressing themselves without getting into the prosecutor, defendant, judge roles in which so many people find themselves. Usually, the goal is not to eliminate jealousy, since this invalidation and suppression approach seldom works, but rather to find ways of incorporating envious feelings and ideas in a relationship. After all, jealous emotions usually originate from a sense that things matter, and that somebody is unique to you, and that it is not something that people want to get rid of. Chapter 9. Tension and Emotional Eating. The majority of the dieters whom I deal with eat way too much when they're feeling stressed out or experiencing an unfavorable emotion like anxiety, sadness, anger, embarrassment, and so on. They often have one or both of the following unhelpful ideas. There's nothing I can do to calm down when I'm upset. I are worthy of to eat when I am upset. As long as they hold beliefs like these, they will remain vulnerable to regaining the weight they have lost. They need to change their thinking. They need to learn how to accept and tolerate negative feelings and how to handle tension in more healthy ways. Katie, a dieter whom I saw last year, had been doing so well at first. Early on, she was highly inspired and had the ability to remain on track, even when she was upset. When she ended up being upset, she would tell herself, "No option, it's not time to eat. I can't eat now." She would turn her attention to something else. Her negative feelings would slowly subside, and she'd feel proud that she had stuck to her plan. But when Katie went through a particularly demanding period, her dad was hospitalized. Her youngest kid started having issues in school. She got a new supervisor at work who was making unreasonable demands on her. Katie went on to follow her eating plan throughout each day. Still, come 9 p.m., when her children were in bed, the approval-granting beliefs above led to Katie's taking in all the carbs I can get my hands on till she went to sleep. She rapidly started gaining back the 22 pounds she had lost. She was disappointed and angry at herself, but could not seem to stop. First, Katie and I did some problem solving. As soon as she got her kids in bed, she would decompress by doing deep breathing, and then she'd have a cup of herbal tea. Next, we did some cognitive work. Following our discussion, Katie made up messages on index cards which she was to read each day after work, right before she walked in the house. She was to read them again as she was sipping her tea. This is what Katie's card said. "If I want to reduce weight permanently, I have to stop eating when I'm upset. Every time. Most people without weight problems do not eat when they are upset. They either tolerate their negative feelings, or try to solve the problem, or call a friend, or take a walk, or browse the web, or read a magazine, or watch television. But they don't eat." Negative feelings are uncomfortable but not hazardous. I do not have to fix them. I have had a ton of times when I felt very upset, but I haven't eaten. I've never ever exploded or lost control. The worst thing that will happen if I do not eat is that my distress will peak, and then the strength of my feelings will go down. If I eat, I'm going to be temporarily distracted from my distress, but whatever issue caused my distress in the first place will still be there, and then I will also have the issue of feeling badly that I ate, and I am going to actually feel badly when I see that the scale has gone up. Katie also drew back on day 1 of the cognitive behavioral program for weight loss and upkeep, so she could sharpen her skills of remotivating herself, acquiring self-confidence by giving herself credit, enduring cravings, and getting back on track immediately when she made a mistake. The incidence of her eating for psychological reasons declined greatly. She slipped sometimes, but the difficulty ended up being easier and easier as time went on. The chance that Katie will have the ability to maintain her weight reduction into the future has increased significantly. Chapter 10. Rational Emotive Behavior Treatment. Rational Emotive Behavior Treatment, REBT, is a short-term form of psychotherapy that helps you identify self-defeating thoughts and feelings, challenge the rationality of those feelings, and change them with healthier, more productive beliefs. REBT focuses mainly on the present time to help you understand how unhealthy thoughts and beliefs develop psychological distress, which in turn results in unhealthy actions and habits that hinder your existing life goals. Once recognized and understood, negative thoughts and actions can be changed and changed with more positive and productive conduct, enabling you to develop more successful personal and professional relationships. In practice, REBT can help you with negative emotions such as anxiety, depression, guilt, and extreme or inappropriate anger. This technique is also used to help change difficult and self-defeating behaviors, such as hostility, unhealthy eating, and procrastination that obstruct of your lifestyle and reaching your goals. What to expect? To help you manage and get rid of troubles or attain life objectives, the therapist will work with you to determine the beliefs and stiff idea patterns that are holding you hostage. The therapist will help you see how unreasonable these thoughts are and how they harm you. Through a range of mental workouts, you're going to then learn how to decrease your negative thoughts and reactions and replace them with healthier, more useful, and self-accepting ideas. REBT makes use of a range of methods and tools, including but not limited to positive visualization, reframing your thinking, and the application of self-help books and audiovisual guides, as well as assigned homework for reinforcement between sessions. How it functions. REBT progressed from the work of psychiatrist Albert Ellis in the mid-1950s as the original form of cognitive behavioral treatment. Ellis actually believed that many people aren't aware that lots of their thoughts about themselves are irrational and negatively impact the way they behave in important relationships and circumstances. According to Ellis, it is these ideas that lead people to suffer negative feelings and participate in self-destructive behavior. At the same time, people have the capability of challenging and changing their irrational beliefs if they are willing to do the work. While specific life events might contribute to mental health issues, REBT therapists actually believe that it is an individual's own faulty and unreasonable belief system that triggers the most problems. By releasing negative ideas and changing them with positive beliefs, one is better able to accept somebody's self and others, and, in turn, live a better life. This has been Cognitive Behavioral Therapy. Retrain your brain and heal from trauma. Written by Zimbob Winston. Narrated by Rory Young. Cognitive Behavioral Therapy. Defeat anxiety and depression once and for all. Written by Zimbob Winston. Narrated by Rory Young. Chapter 1. Cognitive Behavioral Therapy for Depression. As the holiday is upon us, now is a good time to consider cognitive behavior therapy, CBT, for depression. Ironically, the all-time Christmas traditional It's a Wonderful Life, directed by Frank Capra and starring Jimmy Stewart and Donna Reed, presents the essential components in CBT. CBT is the new buzzword for psychiatric therapy, as Freudian psychoanalysis once was. Every therapist now claims to use it, if they're not psychiatrists who rely strictly on drug treatment. But most are just paying lip service to the treatment. Before turning to Capra's genius, let me first answer the question, have not antidepressants, ADs, transformed, resolved truly, the problem of depression? No, they haven't. Here are 3 points to consider. 1. As all medical suppliers will tell you, symptoms of depression persist for the large bulk of AD receivers. 2. Medical trials involving psychedelic placebos find negligible added advantages for ADs versus those produced by the placebos. 3. Head-to-head comparisons of CBT and AD yield equivalent preliminary results, but far less regression from CBT. The lower regression rate for CBT takes place because it teaches people particular techniques to utilize in their lives which they keep, while withdrawal from advertisements is often traumatic. What makes CBT so misleading is that it is a prescription for sound judgment. CBT tells people to schedule and force themselves to remain involved in work, play, social activities. It also teaches them to practice easy cognitive prophylactia, as shown in It's a Fantastic Life. When people commit suicide, we often grieve that they had so many positives in their lives which they ignored in favor of some current bad events. These mental injuries, or fears more regularly, completely dominate depressed people's thinking and become intolerably dire in their minds. Naturally, if they waited for events to cycle through, they would find their problems are often less extreme than they initially feared, and that they can be readily solved. In the meantime, if people weather the storm, they refocus on their positives: family, basic enjoyments, past accomplishments, good friends they may have forgotten, and so forth. Clarence the Angel performs this refocusing task for George Bailey, Jimmy Stewart, in It's a Wonderful Life. George is on the brink of suicide both because he feels he has squandered his life and just because he's faced with a company crisis. Clarence helps George to recover pictures of all of the positive deeds George has performed over his lifetime. Remembering these images causes George to see how many people in his own community he has helped and how much good will he can contact. After this vision, George returns home with a new appreciation for the small things around him, even the dissatisfactions and stressors, and for his loved ones. This is the kind of awakening people often report after they almost die. If only we could help depressed people crystallize such realizations without having them face death, then we'd have a therapy. CBT helps people to learn these cognitive lessons so that they can produce for themselves the same magic that Clarence performed for George. And Clarence's presentation of CBT is the reason that It's a Fantastic Life has stuck with us for what appears like, well, an eternity. Chapter 2. Cognitive Behavioral Therapy Instead of Sleeping Pills. Sleeping disorders is a typical sleep disorder that can make it hard to drop off to sleep, hard to stay asleep, or cause you to wake up too early and not have the ability to return to sleep. Cognitive behavioral therapy for sleeping disorders, sometimes called CBTI, is an efficient treatment for chronic sleep problems and is typically recommended as the first line of treatment. Cognitive behavior therapy for insomnia is an organized program that helps you determine and replace thoughts and habits that cause or get worse sleep problems with practices that promote sound sleep. Unlike sleeping pills, CBTI helps you get rid of the underlying causes of your sleep problems. To identify how to better treat your insomnia, your sleep therapist may have you keep a comprehensive sleep journal for 1 to 2 weeks. How does cognitive behavior therapy for sleeping disorders work? The cognitive part of CBTI teaches you to recognize and change beliefs that impact your capability to sleep. That type of therapy can help you control or get rid of negative ideas and concerns that keep you awake. The behavior part of CBTI helps you develop good sleep habits and keep from habits that keep you from sleeping well. Depending on your specific needs, your sleep therapist may suggest some of these CBTI methods. Stimulus control therapy. This method helps get rid of factors that condition your mind to resist sleep. Here's an example. You might be coached to set a constant bedtime and wake time and keep away from naps, use the bed only for sleep and sex, and leave the bedroom if you can't go to sleep within 20 minutes, only returning when you're drowsy. Sleep constraint. Lying in bed when you're awake can become a habit that results in poor sleep. This treatment lowers the time you spend in bed, triggering partial sleep deprivation, which makes you more tired the next night. Once your sleep has enhanced, your time in bed is gradually increased. Sleep hygiene. This technique of treatment includes changing fundamental lifestyle practices that influence sleep, like smoking or drinking too much caffeine late in the day, drinking way too much alcohol, or not getting regular exercise. It also includes suggestions that help you sleep better, like ways to unwind an hour or more before bedtime. Sleep environment improvement. This offers ways that you can produce a comfortable sleep environment, like keeping your bedroom quiet, dark, and cool, not having a television in the bedroom, and hiding the clock from view. Relaxation training. This technique helps you relax your mind and body. Approaches include meditation, imagery, muscle relaxation, and others. Staying passively awake. Also called paradoxical intention, this involves staying away from any effort to fall asleep. Paradoxically, stressing that you can't sleep can actually keep you awake. Releasing this concern can help you unwind and make it easier to fall asleep. Biofeedback. This approach allows you to observe biological signs such as heart rate and muscle tension and shows you how to change them. Your sleep specialist may have you take a biofeedback device home to make a record of your daily patterns. That information can help recognize patterns that influence sleep. The most effective treatment method could combine several of these methods. Cognitive behavior therapy versus pills. Sleep medications can be an efficient short-term treatment. For instance, they can supply instant relief throughout a period of high stress or sorrow. Some newer sleeping medications have been approved for longer use. However, they may not be the best long-term insomnia treatment. Cognitive behavioral therapy for sleeping disorders might be a pretty good treatment choice if you have long-lasting sleep problems, you're stressed over being dependent on sleep medications, or if medications aren't efficient or trigger irritating side effects. Unlike pills, CBTI addresses the hidden causes of sleeping disorders rather than just easing signs. However, it takes some time and effort to make it work. In many cases, a mix of sleep medication and CBTI may be the best technique. Insomnia and other conditions. Sleeping disorders is linked to some physical and psychological health conditions. Ongoing absence of sleep increases your risk of health conditions like hypertension, cardiovascular disease, diabetes, and persistent pain. Some medications, including non-prescription medications, can also contribute to sleeping disorders. If you have a condition or medication that is linked to sleeping disorders, speak with your doctor about how best to manage these along with sleep problems. Insomnia is not likely to get much better without treatment. Finding help. There are a limited number of licensed behavioral sleep medication experts, and you could not live near a practitioner. You may have to do some searching to find a qualified professional and a treatment schedule and type that fit your needs. Here are some spots to look. The American Academy of Sleep Medication website enables you to search for a certified sleep center, like Mayo Clinic Center for Sleep Medication. The Society of Behavioral Sleep Medicine website offers a directory for finding a behavior sleep medicine company. The kind of treatment and frequency of sessions can differ. You may need as few as 2 sessions or as many as 8 or more sessions, depending on your sleep specialist, the program, and your progress. When calling them to establish a visit, ask a professional about his or her technique and what to expect. Also, check in advance whether your medical insurance will cover the type of treatment you really need. If available in your area, meet with a sleep medication specialist personally for your sessions. Nonetheless, phone assessment, CDs, books, or sites on CBT strategies and sleeping disorders also could be beneficial. Who can gain from cognitive behavior therapy for insomnia? Cognitive behavioral therapy for insomnia can benefit almost anyone with sleep issues. CBTI can help people who have primary sleeping disorders and also individuals with physical problems, such as persistent pain, or psychological health conditions, such as depression and anxiety. What's more, the results appear to last. Also, there is no evidence that CBTI has negative bad effects. CBTI needs steady practice, and some approaches could trigger you to lose sleep at first, but persevere and you will likely see enduring results. Chapter 3. How CBT unwraps ADHD negativity. After a lifetime of errors, incidents, and missed due dates, is it any marvel that grown-ups with attention deficit hyperactivity disorder, ADHD or ADD, suffer dangerously low self-confidence and perpetually negative thoughts? Cognitive behavior therapy, CBT, is a short-term, goal-oriented form of psychotherapy that aims to change these negative patterns of thinking and change the way a patient feels about herself, her capabilities, and her future. Consider it brain training for ADHD. CBT aims to change unreasonable idea patterns that prevent individuals from remaining on job or getting things done. For an individual with ADHD who thinks, "This needs to be perfect or it's no good," or I never ever do anything right. CBT challenges the truth of those cognitions. Changing distorted ideas and the resulting change in conduct patterns is effective in treating anxiety and other emotional issues. How does CBT help people with ADHD? ADHD is a persistent, consistent holdup of self-regulation abilities, including executive functioning abilities. Holdups in EFs create procrastination, poor organization, poor time management, emotional dysregulation, impulsivity, and irregular motivation. Even though these issues aren't included in the main diagnostic requirements for ADHD, they are common in adults with the condition, making it hard for them to manage their feelings and habits. People who grow up with ADHD, particularly if it has gone undiagnosed, encounter more regular and discouraging problems in life circumstances, on the job, in social interactions, and daily organization. Because of these many obstacles, grown-ups with ADHD become self-critical and cynical. This, in turn, at times causes them to experience negative feelings, cognitive distortions, and unhealthy self-beliefs. It is very common for people coping with ADHD to think they're at fault when situations do not turn out well, when in many cases they aren't. They might bring the exact same pessimism to the future, picturing that tomorrow will go as badly as today. Demoralizing thoughts and beliefs that keep individuals from doing what they want to do actually can't withstand the light of logic. As CBT reveals, these thought processes are misshaped in certain particular ways. All or nothing thinking. You view every little thing as totally good or totally bad. If you don't do something perfectly, you've failed. Overgeneralization. You see a single negative event as part of a pattern. For example, you always forget to pay your costs. Mind reading. You think you know what people think of you or something you have done, and it is bad. Fortune telling. You forecast that things will turn out badly. Magnifying and minimization. You overemphasize the value of small issues while trivializing your accomplishments. Should statements. You focus on how things should be, causing severe self-criticism and emotions of bitterness to others. Customization. You blame yourself for negative events and downplay the responsibility of others. Psychological filtering. You see only the negative aspects of any experience. Emotional thinking. You presume that your negative feelings show reality. Feeling bad about your job means, I'm doing badly and will most likely get fired. Comparative thinking. You gauge yourself against others and feel inferior, although the comparison may be impractical. Learning to recognize these distorted thoughts helps you to change them with practical thinking. Understanding how you think is an effective start to making changes in your life, says J. Russell Ramsey, Ph.D., Assistant Professor of Psychology at the University of Pennsylvania. Changing ideas and changing conduct work hand in hand. Expanding your view of a circumstance makes it possible to expand the ways you can deal with it. How has CBT for ADHD changed? Since 1999, various research initiatives have studied the impact of CBT on the symptoms of ADHD in adults, in both individual and group formats, with a majority of the studies being released in the past 5 to 10 years. By and big, this research supports the assertion that CBT can help grown-ups better address their ADHD-related challenges. Here's an example. A 2016 neuroimaging research study of adults with ADHD who completed a 12-session course of CBT revealed improvements in ADHD symptom ratings and useful changes in the exact same brain areas that are generally kept an eye on in research studies of medication treatment. Still, some in the scientific community wishes to see more rigorous research conducted with carefully built controls. In its 2011 report titled Present Status of Cognitive Behavioral Therapy for Grown-Ups, Attention Deficit Hyperactivity Disorder, scientists from Massachusetts General Healthcare Facility and Harvard Medical School, wrote, "The conceptual and empirical basis for CBT approaches in adult ADHD is growing and suggests that targeted, skills-based interventions have a vital role in successfully treating this disorder. At this stage of development, though, subsequent research studies must advance regarding methodological rigor. Additional randomized controlled trials with active control groups are needed, and intervention packages must be tested across multiple trials by more than one research group." How precisely does CBT improve ADHD in grown-ups? While it is fascinating to learn how CBT may change the brain, most clients with ADHD just want to get out the door without losing 20 minutes trying to find their keys. CBT helps clients manage such daily challenges. CBT steps in to enhance life has a hard time, procrastination, time management, and other common problems, not to treat the core signs of negligence, hyperactivity, and impulsivity. CBT sessions concentrate on identifying the circumstances in which poor planning, disorganization, and poor time and job management develop difficulties in a patient's day-to-day life. Sessions might help an individual handle obligations, such as paying bills or finishing work on time, and motivate undertakings that offer personal fulfillment and wellness, like sleep, exercise, or pastimes. Learning about ADHD is always a good beginning point, as it strengthens the message that ADHD isn't a character flaw and demonstrates the neurological underpinnings of daily difficulties. Most grown-ups with ADHD say, "I know what I really need to do, I just do not do it." Regardless of having prepare for what they really want or really need to do, they don't carry them out. CBT focuses on adopting coping strategies, handling negative expectations and emotions, and unwinding behavior patterns that hinder the techniques. The goals and session programs of CBT center on scenarios and difficulties that the patient has experienced and, more vital, expects to encounter, especially between sessions. The therapist uses takeaway reminders, follow-up check-ins, and other ways of using new survival skills so they are used beyond the consulting room. Ultimately, the way that a patient with ADHD functions in everyday life is the best step of whether the therapy is helping. What is a common CBT session like? CBT is administered in many different formats, and each therapist tailors sessions to a patient's individual needs. Each session's agenda offers a standard for identifying when the discussion is straying off course. Early sessions generally include an intro to CBT, the structure of sessions, and setting and refining therapy objectives, making them specific, sensible, and actionable, as well as developing action prepare for what the patient will do outside of the office. Subsequent sessions focus on determining the most crucial life circumstances affecting the patient and developing coping skills to manage those circumstances. One of the myths about CBT is that it neglects childhood and the past. These early life experiences are the raw materials from which people develop deep-rooted, non-conscious beliefs and rules for how the world is and our role in it. That originates from human capability to classify experiences to learn, understand, and predict and manage new circumstances. The patient's comprehension of her or his guidelines for the world is a vital objective in CBT. Uncovering the roots of the rulebook helps grown-ups with ADHD understand the patterns in their self-criticisms, or criticisms of others, avoidance patterns, and self-defeating habits. Ultimately, the primary objectives of CBT are to get rid of impairments and to execute coping strategies. CBT helps in processing new experiences and finding new ways to deal with setbacks. It adapts the old rules to align with present-day life. For each agenda product, the therapist and patient interact to reverse engineer the obstacle. Then they try to better understand its nature, including but not limited to an evaluation of the impact of ideas, emotions, habits, and other elements that have interfered with handling the circumstance. Using the CBT framework breaks down the tough task of handling ADHD into specific tactics for navigating shift points in a day, getting up and off to work on time, starting a project that you've been avoiding, or setting a time to examine a daily coordinator, which increases coping skills. Those coping steps are planned in a session and jotted down as takeaway reminders to use between sessions. Some of the in-session CBT exercises are based upon basic ideas. Lots of people with ADHD don't wear a watch, says Dr. Mary Salanto, Ph.D., Associate Professor of Psychiatry at the Mount Sinai School of Medication. Still, recalling to wear a watch, placing clocks all over the home, and keeping an in-depth log of the day helps a lot with time management. How does someone with ADHD remember to do all that? Simple mantras, if it's not in the planner it doesn't exist, are basic forms of CBT. They serve as reminders to change one's thought patterns. We teach them that, if they are having actually trouble starting on a project, the first step is too big, Salanto says. Salanto advises her clients to document in their ADHD-friendly organizers each job they need to do in an offered day, from important consultations to everyday errands. She asks clients to link checking the organizer to routine activities, like brushing your teeth, eating lunch, walking the pet dog, and so forth. This helps someone with ADHD remain on task throughout the day and prioritizes the important things to get done. Those with ADHD spend a lot of time putting out fires instead of planning ahead to stop those fires, says Salanto, who has recently outlined her work in cognitive behavioral therapy for adult ADHD, targeting executive dysfunction. The book teaches therapists how to apply and use Salanto's brand name of CBT in their own practices. CBT makes it easy to address other important concerns that influence ADHD signs: coexisting state of mind and anxiety disorders, dependence on innovation and gaming, a job search, or overall living style routines, sleep, exercise, and someone's self-confidence. How do CBT and medications mix? Rather well. For some people, using ADHD medications alone leads to both sign improvements and better management of adult responsibilities. Most people, however, find that they need CBT to target continuous struggles with poor organization and procrastination, in spite of being on ADHD stimulants. As has been said many times, pills do not teach skills. The mix of medication and CBT is usually the treatment of choice for dealing with the extensive effects of ADHD. There's no proof that CBT can change drug treatment for ADHD, or perhaps permit lower dosages, but research does suggest that it works better for ADHD than do other forms of therapy. A 2010 study by Boston's Massachusetts General Hospital found that a mix of drug treatment and CBT was more efficient at controlling ADHD signs than was drug treatment alone. CBT picks up where medication ends, says Stephen A. Safran, Ph.D., leader of the study and assistant professor of psychology at Harvard University. Even after optimum treatment with medication, most grown-ups have recurring signs, and this treatment appears to make them better. When can I expect to see results? Results come rapidly. CBT typically yields advantages after only 12 to 15 one-hour sessions. Still, most clients continue with CBT much longer, as it stresses long-lasting maintenance of survival skills and improvements. In fact, the length of time spent in treatment, over many months, say, is as important as the number of sessions an individual undergoes. Some people ask whether they are supposed to take a month off from work or school and do a CBT boot camp for 4 or 5 weeks. That is generally not advised. CBT aims to help individuals make sustained changes in their everyday lives. Rather than going to 20 everyday sessions of CBT in a month, a patient ought to extend those sessions over 6 months to turn his new abilities into habits and to weave them into his lifestyle. That permits time and practice for mastering coping strategies for paying monthly costs, organizing work or school issues, and pursuing other jobs and endeavors in real time. Some individuals return to CBT for booster sessions to resolve a challenge if they've fallen into old routines. Some resume CBT to adjust their survival skills to a major life change, like having a kid or losing a job. Chapter 4. Cognitive Behavioral Strategies for Dropping Weight That Work. When we think of weight loss, we often think about what we eat. The questions we ask ourselves tend to revolve around how much fat, protein, and carbohydrates to eat, or whether beets help remove the pounds. Diets touted in the media as optimum for weight loss are plentiful, yet we remain a nation with an obesity issue. What we tend to neglect when we think of weight loss is how we're approaching and managing the process of change. As crucial as it is to focus on what you eat to lose weight and keep it off, it is equally crucial to consider physical activity and keeping living style changes in time. How to make behavioral changes, what strategies we use to comply with new ways of eating, and increasing physical activity cannot be ignored. The problem is that making changes to your living style is hard. If it weren't, we wouldn't have an obesity epidemic in this country, nor would estimated healthcare expenses for physical inactivity have been $76.6 billion in 2000. Undoubtedly an older figure, but not likely to have improved substantially in recent years. Cognitive behavior therapy, CBT, which focuses on changing how you think about yourself, how you act, and scenarios that surround how you act, is an effective treatment for a wide range of problems, including but not limited to weight loss. The key to it is its concentrate on making changes and adhering to them. So what CBT techniques help people to slim down and change living style conduct? 1. Goal setting. If you really want to meet the objectives you set, then consider the following 3 elements. The more particular an objective, the more likely you are to accomplish it. Enthusiastic objectives are good, but overly enthusiastic goals can be discouraging. Routine feedback on progress enhances outcomes. When it pertains to weight loss, then, an objective to eat fruit for dessert rather than cake is specific and can be plainly tracked. Particular objectives around exercise or types of food you are going to eat, behaviors you have control over, are better than goals to enhance cholesterol or glucose levels, which may vary for reasons outside your instant control. 2. Self-monitoring. Self-monitoring requires that instead of beating yourself up for not achieving an objective, you attend to your own individual experiences. When you self-monitor, you begin to notice barriers, pay close attention to physical cues, and determine challenges to changing your conduct. Too often we count on negative self-judgment to stay inspired, and in so doing, fail to recognize and prepare for real barriers. You can think of yourself as a researcher when you self-monitor. You may want to keep a log of your food intake or exercise regimens, for instance. And doing so will help you to problem solve when life has gotten busy or you leave track. With greater awareness of your own experience, you are better able to find ways to maintain new habits when preliminary motivation is subsiding. 3. Feedback and reinforcement. It can be helpful to get feedback from outside sources. Having a healthcare company regularly sign in with you can supply an external measuring stick. Feedback about your diet or exercise regimen can supply motivation or help you change your conduct. Outside feedback can also help you keep your expectations ambitious but sensible. 4. Enhancing the belief that you can do it. When you go into any circumstance with the mindset that you will definitely fail, you considerably reduce your chances of succeeding. It is necessary to focus not just on behavior, but also on your perception of your capability to make the changes you want. The best way to improve your belief in your capability to be successful is actually to have some success. Setting concrete and attainable objectives, such as eating fruit at breakfast or replacing an after-dinner television show with a walk, can build your confidence to set more enthusiastic objectives. If you're wanting to improve your sense that you can do it, it also can help to look for people in similar scenarios who have made the hard changes you are attempting to make, and to surround yourself with people who will encourage your efforts. 5. Rewards. The application of incentives to support change in conduct has been thoroughly studied, and the idea is now being applied to gaining back and preserving physical health. Examples include businesses that offer lower-priced on-site physical fitness centers as an incentive to work out, offering cash incentives and gift cards, supplying free health coaching, and offering insurance premium discounts to the one who meets certain requirements. Adopting a much healthier lifestyle isn't just a matter of changing the foods in your cupboards. Living style changes take continual efforts and time, and whether we achieve our objectives depends upon how we make them, our frame of mind, and what we put in place to maintain motivation. Chapter 5. Treatments for OCD. Most CBT treatment is conducted at a therapist's office once a week with exercises to practice in the home between sessions. If your OCD is very severe, you might really need more frequent sessions. Not all psychological health experts are trained in ERP treatment, so it is necessary to find someone who is. One key to understanding whether you have found a suitable ERP therapist is if the therapist encourages you to take part in exposure exercises throughout your sessions in the office. That helps you take part in more direct exposures beyond the office. Just discussing doing them in the office is less reliable than starting with the real direct exposures. The supreme goal of therapy is to turn direct exposure to the real world, where you can withstand your compulsions, and where you can embrace unpredictability instead of fear it. Exposure therapy. The psychotherapy of choice for the treatment of OCD is exposure and response avoidance, ERP, which is a type of CBT. In ERP therapy, people who have OCD are put in situations where they are slowly exposed to their obsessions and asked not to perform the compulsions that generally ease their anxiety and distress. That is done at your rate. Your therapist ought to never force you to do anything that you do not want to do. The first step is for you to specify all of your obsessions and compulsions. Then, you and the therapist will arrange them in a list, ordering them from things that do not bother you much to things that are the most frightening. After that, the therapist will ask you to face your fear of something on your list, starting with the most convenient. Let's say you have a compulsive fear of bacteria in public spots, and that fear is pretty low in how much it frightens you. Your therapist will design a job for you that exposes you to that fear. Your task might for you to touch a public doorknob. Here's where the response prevention part comes in. If your typical reaction is to wash your hands instantly after touching the doorknob, the therapist would ask you to wait before you wash your hands. As you repeat this direct exposure job, the therapist will ask you to wait longer and longer before cleaning your hands. With time, this steady exposure and postponed reaction would help you learn how to control your fear of germs in public areas without cleaning your hands. It might seem weird, but this new way of challenging your fears straight will cause fewer and less intense fears or fixations about germs. Your brain learns that absolutely nothing bad happens when you stop carrying out compulsive routines. You'd most likely feel mad when you initially touch the doorknob, perhaps even feel a little panicked. Having said that, the body has a wonderful capability for something called habituation, and anxiety will eventually lessen without doing anything but letting time pass. It is something like delving into a pool of cold water. When you jump in, the water might feel extremely cold. Having said that, after a while, your body gets used to the cold, thanks to habituation, and you feel fine. When your therapist helps you with exposures over a period of time, your anxiety shrinks until it is hardly noticeable, or perhaps fades totally. The therapist can then help you get confidence and learn unique skills to manage the compulsions through a cognitive therapy. Imaginal direct exposure. For the ones who may be resistant to leaping right into real-world situations, imaginal exposure, i.e., in some cases referred to as visualization, can be a valuable way to relieve enough anxiety to move willingly to ERP. With visualization, the therapist helps develop a circumstance that generates the anxiety a person might experience in a regular circumstance. For someone who fears walking down a corridor in a way that diverts from their perfect pattern, the therapist could have them visualize themselves walking in that divergent way for several minutes each day and make a record of their level of anxiety. As they habituate to the pain, with reduced anxiety gradually, they're slowly desensitized to the feared circumstance, making them more willing to move the process to real life and participate in the next step, ERP. Routine turnaround training. This intervention includes awareness training, introduction of a completed reaction, social support, positive reinforcement, and often relaxation methods. Awareness training could be practicing the practice or tick in front of a mirror, focusing on the experiences of the body and particular muscles before and while taking part in the conduct, and recognizing and tape recording when the practice or tick happens. These techniques increase consciousness of how and when the urges develop, making it more likely that an individual will be able to step in and make a change. That is where the contending reaction comes in, with the individual and therapist working together to find something comparable to the movement or tick that isn't visible to others. A person with a vocal tic who learns awareness of the developing urge may practice tensing the muscles around their cheeks and mouth to ride out the urge and stop the tic. Or somebody with a compulsion to touch things symmetrically might be directed to tense the opposite arm, holding it securely against their body, stopping them from completing the routine. This technique of treatment takes some time, through practice and some patience, and integrating relaxation skills just before starting. Also very critical to success is the support and positive reinforcement of family. Cognitive therapy. When applied to treating OCD, cognitive treatment helps you understand that the brain is sending out mistake messages. Your therapist will help you learn to recognize these messages and react to them in new ways to help you control your fixations and compulsions. Cognitive therapy concentrates on the meanings we connect to certain experiences that we misinterpret. An example would be the following. If a friend passes you without recommendation, you may interpret her action improperly and think, Mary doesn't like me because she didn't say hello. And you might actually believe your idea is really crucial or meaningful. Cognitive treatment helps you stand back from these ideas, look at the evidence carefully, and tell yourself something more practical or accurate. In this case, it might be, something is on Mary's mind, but I do not know what it is. Cognitive treatment for OCD concentrates on the experience of negative ideas. While most people quickly dismiss such thoughts, or in other words, that's a ridiculous thing to think, some people have certain beliefs that thoughts are always essential. So rather than being able to just forget these negative thoughts, their beliefs trigger them to respond in a different way and may make them think, I'm an enemy for having such a thought. Research shows that believing that negative thoughts are essential and trying not to have bad ideas actually produces the opposite impact. This has been Cognitive Behavioral Therapy. Defeat Anxiety and Depression Once and for All. Written by Zimbab Winston. Narrated by Rory Young.